So first of all, I think good morning, good afternoon, everybody. I think we have folks joining from all coasts here in the US, and thank you all for joining. My name is Vineet Singhal. I lead the payers and the UiPath charter for Genzeon. On behalf of both our teams, UiPath and Genzeon, I'm delighted to welcome, I think what I see is an approaching 100 numbers from registrations, I can tell 30 odd payer organizations. So extremely honored and looking forward to be in this esteemed company and a brilliant conversation on what we will be focused on is future of prior authorization automation. I think we'll be talking about both elements, an automation way or an RPA way, also including the agentic way, and we'll introducing all the body of experience of work that we have been experiencing with multiple payer organizations. I think just a quick note on logistics. If you have questions, I think there's a Q&A tab that you see. Please drop your questions in that Q&A tab. I think chat might be disabled for a webinar setting. So appreciate you putting your questions. I think we'll try to take questions as much as possible during the conversation and we'll answer them. If any questions remain unanswered, I think towards the end of the webinar, I think we'll try to take them in en masse. I think what we'll be focused on, I think for us, this session is more than compliance. I think with the CMS final rule 0057, I think our industry had faced challenges and opportunity together. And I think what we've seen in last 3 years or so, I think from early release to the interactions that we have been having with different payer and ecosystem organization, I think the challenge has been around tighter SLAs, mandated transparency, interoperability requirements. I think we are seeing this turning into an opportunity, into a self-funded transformation initiative, improving turnaround times, reducing clinical burden, enhancing, most importantly, member and provider ecosystem and community experience. I think towards that end, I think what we thought of what we would do is probably with the context of CMS mandate in an industry trend, I think side chat between Harsh and Sophia for the first couple of minutes to take their perspective on what mandate, what pain points, what quick wins they are seeing with different payer customers that we're working with. Then we will get into a quick process view of the opportunity of prior auth process in multiple ways, as I spoke about before. We'll do 2 live demonstrations of an end-to-end prior auth process and a clinical decision agent around a clinical specialization. And I think we'll talk more about as we cover our solution approach. And last but not the least, I think we'll try to give you an invitation to our participation in Fusion as a proud sponsor, where we are trying to create a Fusion prior auth community with your support. I think with that, and I think, of course, there will be an opportunity to ask questions throughout this conversation and towards the end of this conversation. But to that end, I think let me start the fireside chat. And I think the first question that I had both Sophia and Harsh for you is, since the guidance has been released or the regulation has been released in its early version in December 2022, I think we have seen reactions on both spectrum, right? I think there are payers who have spoken about complete elimination of prior auth to folks who are only thinking of it as a compliance checklist. What are you seeing? What are you listening? What are you hearing from the community in general?
Yeah, absolutely. I'm happy to take that first. So you're right. I think we're seeing this huge spectrum, and there's been this pendulum swing of really kind of reactive responses. I think what we're seeing with partners is definitely an iterative approach. And anything from RPA automations to agentic. So there's a ton of activity in agentic right now. There's some really, I would say we have 5 to 6 POCs right now just in prior auth. Doing more of like the clinical reasoning, deep medical record summarization, that's really exciting. If you think about kind of a mirror process and applying some of those same capabilities, we have even more POCs on the appeals and grievances. So even where you're using this super transformative technology like agentic, I think partners are still being surgical about what is the business challenge I'm solving for and applying an agent to that. And then outside of the agentic, I think we're still seeing a ton of optimization and automation with RPA. So things like intake, building cases, communication generation, even like upgrading. So where I had machine learning models doing this intake, maybe I can do generative extraction there. So really exciting stuff on both fronts there.
Thanks, Sophia. I think that's what's happening on the ground today. I think, I look back a little bit. I think when this regulation was announced, maybe in 2022, when the initial conversation started, I think, Vinith, you are right. They started with, hey, could we truly do gold carding and also do analytics to determine if we could sunset some of these prior auth requirements. It started from that pendulum, I think, all the way on the extreme to see what could be done. I think to Sophia's point, I think in 2024, 2025, we are very much seeing pendulum swing towards a little bit more of a reality check on, hey, maybe that's 10, 15% where we could do gold carding and where we could essentially eliminate prior auth, but 85%, 90% of the situations we still need prior auth and we need automation and AI to be leveraged to be able to effectively reduce the clinical burden and improve the productivity of the nurses, right? So I think when I see now, as of today, when those conversations are happening, I see a segmented view of payers in one of two categories. One of them who are purely viewing this as a compliance exercise, as regulations continue to come, we continue to see that payers sometimes will feel this is a needed compliance checkbox and there is a spend of $1 to $5 million just to be compliant, or you see this as a transformational opportunity to your clinical operations platform on the other extreme, where most progressive payers, when we think about folks like United, Aetna, Elevance, these guys are investing heavily into exploring how to actually bring automation to bear, improve the workloads for their clinical teams. And I think that's where it's very much a strategic opportunity. But if we are approaching this today as a compliance checkbox, I would suggest you look and explore and talk to your other competitors, other fellow payer members, and see how they are approaching it. And what we are finding is there is a significant opportunity to improve the clinical operations. And actually, I think Vinith used the word self-funded, create a program that actually ends up being self-funded over a period of time. So huge, huge opportunity. I think quite excited about the conversation and the work that's going on across few of our clients.
Perfect. I think towards that end, I think considering that it's been a 3 year of journey in making, what are the most common barriers or pain points that you have heard payers speak about, I think, as they are trying to tackle this regulation and are trying to take this transformation journey for the ones who are believing in transformation or any engagement approach that they are trying to solve towards this?
Yeah, Vinith, I think one of the most interesting things, I think we sometimes forget that we live in a world where most payers, where the clinical operation still runs in the legacy platforms. And I think there is a huge tech burden that exists when you're trying to transform certain elements of this exercise. And I think I look even on the provider ecosystem. I think three-fourths of the providers have multiple payer portals they're dealing with. They're dealing with channels where they're still faxing. There are elements of paper that continue to actually happen as well, not just faxing, which is amazing in this day and age. And obviously, submission over EDI that continues to happen. So dealing with this complexity, it's a sizable task. And complexity doesn't stop there, right? Even in clinical use cases, you will see that there is low complexity use cases which you could automate more easily, but there is also higher complexity use cases. So there is a whole spectrum of clinical use cases that require a significant level of clinical expertise to be resident within the organization to be able to automate this, or work with your outsourced partners where you might have outsourced radiology or orthopedics in terms of how you fit into the workflow there as well. So significant level of technical complexity exists. And I think, there was a number I was reading recently, across the prior auth, if we just look a little bit broadly on this ecosystem, it's about $35 billion spend that's going on in terms of trying to look at the operational spend in this space. That's where I see this significant opportunity. But I think the complexity of the API that is demanded in Jan 2027 from a regulation standpoint, stats are telling me about 40% of the payers haven't started on that journey, and that's a regulatory demand that's coming in. So a lot happening in this space. At some point in time, would love to kind of hear how the folks on the call are doing in this space as well. But I don't know, Sophia, your thoughts?
Yeah, I would say you can't really overstate the complexity and the nuance and the landscape, the regulatory landscape in prior auth. At the same time, I think we hear from partners regularly, the same things kind of rise to the top, right? I'm having trouble retaining clinicians, they're totally burned out, and how do I reduce turnaround time? I think at times we've seen that sort of get extrapolated into a technical outcome of like, how do I get this confidence level or this auto approval rate? Partners that have been really, really successful are just sort of relentlessly focused on those business metrics. So if I can serve up to my clinician a really tight summary of this case, I've made their life easier, I've reduced turnaround time, I'm controlling my volumes, you're giving lift to the entire process, and that's a win.
Perfect. I think that is a great segue into, I think, what I was going to ask next. I think considering that the number of conversations that we are having and places where we are deploying the solution with clients, what are some of the quick wins for the folks that have not started or are in early phases of starting? And I think because a lot of confidence building happens internally, not only on the technology teams and the business stakeholders, but also the teams that are doing work on a ground basis. What are the quick wins that you guys have either seen or the ones that we have delivered?
Yeah, absolutely. Quick wins are so important to have something to kind of walk and talk around the organization with. I think intake is a huge one. So whether it's fax, paper, generating the EDI, intake is one where you can definitely create a lot of lift with that automation. A lot of partners are using it to build the case in their system. So I think that's another really common one that we're seeing. I think communication generation is a really good opportunity, and this can potentially be an agentic win. So if I think about 6, 7, 8 years ago, I was automating these letter templates by using business rules to insert information, but a nurse still had to come in and they had to rewrite it at a 5th grade reading level. That is work an agent can do today, and a human can, just kind of look at it and make sure it's okay. So that's some of the stuff I'm excited about seeing in the market.
Yeah, that's interesting. I think when you and Sophia, you bring up a point of quick wins. I also hear a little bit of the other side of the conversation where folks are discussing, hey, quick wins can soon turn into point solutions. So I'll just caution the folks as you're exploring the quick win conversation to think in context of the platform solutions and not point solutions. I think it's extremely important because, if you think about quick wins from a perspective of how Sophia described it, it builds upon itself, right? It's a UiPath platform conversation. Yes, you could do the intake, you could do the agentic aspect of being able to look at the guidelines, but also be able to look at how to send the communication back to the providers, right? That builds upon itself. But I'll just caution that sometimes quick wins are looked at. Hey, let's do the communication piece only without looking at the platform, and that has turned out in some of our clients that it actually backfires. So take a platform approach so that all your investments that you're making builds upon themselves, so that again, all of you are on some journey already, right? This is not a program that's starting today. You have made a significant level of investments. The way we are looking at over the last few years, we have made investments working with UiPath is to think about how we can meet you where you are in your journey and build upon that. I think that's extremely important as we look at this. And I would also say that complexity of clinical use cases is a variable that folks need to look at carefully, because a lot of point solutions are coming to the market where they're talking about, I could take a low complexity use case and automate it end to end. But how do you build upon that, right? You're not going to be able to give sometimes your clinical team 6, 7 different systems. So how do you tailor that, and how do you make this as a platform capability where everything comes together? So I think from a clinical and an operational standpoint, it's extremely important to look at that aspect as well.
Okay, I mean, that's really good. I think towards that end, I think you guys have probably been working with Jason a little bit from UiPath team. I think some of you probably would have experience. I think he was planned to be with us in this conversation. I think he has left a message for you guys. I'm going to just play it out. And I think then probably we'll do a voice of customer. I think do a quick poll before we get into the solution. So I think a quick 2 minutes with you, and then we'll get to the poll.
Hello, everyone, and thank you for joining today's session. My name is Jason Bowie, and I lead the Payer Solutions team here at UiPath. I want to start off by saying how much I wish I could be live with you all today. But unfortunately, I'm on site with a national payer customer this week, working hands-on with their team as we apply agentic automation to their claims processing and adjudication flows. It's definitely exciting work, and I'm happy to do it. It's a perfect reflection of all the momentum we're seeing across the market right now as it pertains to agentic AI. But what brings us here together today is one of the most critical areas in the payer space: utilization management and prior auth. These workflows have long been a source of administrative complexity, clinical frustration, and high volume transactions. But with the advancements in intelligent automation and now agentic automation, we finally have a way to dramatically reduce the burden while improving speed, accuracy, and outcomes at scale. UiPath has always believed that the automation is more than just about task efficiency. It's about enabling payers to be more agile, more responsive, and ultimately more human in how they serve members and providers. That vision is why I'm so proud of the work that our partner Genzeon has been leading in the market today. Genzeon has been a deep expert in healthcare operations for several years, but specifically in the prior auth space. And they've been instrumental in helping our customers evolve their automation programs into the agentic era over the last 12 months. Together, we're seeing prior auth workflows become faster, more intelligent, and more aligned with the clinical and regulatory realities we're faced with. I'm excited for you to hear directly from the Genzeon team today. They're a focused partner of UiPath and have a lot of knowledge to share with you all. They'll showcase not only what's possible, but what's already happening in practice. These are real-world situations and solutions that are delivering real value today to payers, providers, and members alike. Thank you again for being here. Thank you for being a part of this important conversation. And I look forward to connecting with many of you in the weeks ahead and continuing to drive innovation in this space using agentic automation.
I think generally I feel we have a good sense of what the results would look like, but looking forward to it. Harsh, that's
It's
probably a
amazing. I think, it's to some degree, I think, most folks are in motion to some way, shape, or form in terms of trying to move forward with their prior auth program. So this is good to hear. I think, as folks who may not be yet in motion, obviously, the deadlines keep on creeping up on us in terms of the regulatory demand. But one of the things I wanted to share here with the group is, as we look at the prior auth space, as we've been working with a few clients of ours, one thing has become extremely clear, and we start to call this, we refer to internally as what we call as the 4x2 grid, which is a grid of complexity and urgency. And I think to some degree, it's become very, very clear that the market is approaching this and currently with aspects of, a lot of solutions in the low complexity space where folks are promising automation. I'm sure you are hearing from a lot of companies saying, hey, they have automated the low complexity use cases, and there is value in doing so. There is, I would say 30 to 40% of your volume essentially is low complexity use cases. And the approach we have taken after talking to a good number of our clients has been that a platform approach which allows you to make investments today and allow to build upon those investments is extremely critical. What I mean by that is, let's say you have solutions that can automate low complexity use cases. And I know Sophia mentioned earlier, hey, there are agents that can do intake. Intake is very similar across all complexity of use cases. Now, decision support is very, very different across all complexity of use cases. So it's extremely important to think about your investments today that you're making in the clinical operations space across this grid of complexity and urgency. And I think look at whether initially maybe you start with the low complexity, have a significant impact. And I would refer to that to some degree as a quick win, but be able to build upon that with medium complexity. When you get into DME and SNF and IRF, these use cases, you end up understanding that you're going to have to build decision agents very, very specific to each of these clinical use cases, right? Because the clinical expertise needed, the training data needed, the models that need to be specifically out there, that need to be trained and tested before they go into production for accuracy reasons. It is extremely important that that level of production testing happens before things are put into motion. And to that end, we have taken this approach of basically looking at it as a layered problem. And today, this platform that we have developed with UiPath exists to be able to provide an impact all the way from low complexity to very high. In very high complexity, obviously, we are interested in making sure it's a human in the loop concept where the individuals who are making decisions, in this case, clinical decision agent is absolutely a human individually reviewing the specific medical guidelines. But even in low to medium to high complexity, we have taken an augmentation approach where we are helping improve the productivity of the nurses who are making these decisions today. And we feel extremely good about having gotten some validation from the clients that this is the right approach for us to be able to create the level of accuracy that's needed in instances where a significant patient care depends upon the decisions being made here as well. So, this is a combination of what I would refer to as automation bots plus agents plus human in the loop to be able to complete this from a workflow standpoint. Again, the approach here is augmentation and focus on approval. There is significant also amount of guardrails being built so that your denial rates are not necessarily higher than what they were. There is some, I would say, negative news that has come out in the industry on the use of AI for the denial rates. And that's primarily happened because of lack of guardrails in certain areas. So we are working with our clients quite actively to make sure the guardrails are in place to emphasize the positive impact of the solution in the market. And to the point of, I think, quick wins that Sophia was discussing earlier, one of the things that we have done over the last 3 years or so is pre-built clinical agents in certain areas. So DME, SNF, IRF, right, PMD. We have spent significant amount of time working with our clinical staff as well as our clients to make sure these agents are ready to have an impact today. We also feel that these agents are not only just applicable in the context of utilization management, but broadly medical management, payment integrity, risk adjustment as well. So the clinical knowledge that's being built into these agents and the models that are being developed have applicability across additional use cases in your environment and to some degree, sometimes in the provider environment as well, to be able to have an impact. So quite excited about the work that's been done. And 20 or so, I think, additional agents are in development today. So we feel like we can have an immediate impact to your clinical operation based on the solution that we present today. And I'm excited to, I think later on in the conversation, we'll get a chance to demo some of that solution. Sophia and myself will go a little bit deeper into a solution demo as well.
So good morning, good evening, everyone. So we have been so far talking about what is happening in the industry, what is art of possible, right? I'm going to, in the next few slides, double click into the process and talk about where RPA agents come in, how they can work in tandem and all those details, right? So let's look at the pre-auth process with the eyes of the two, frontline healthcare workers, right? Here, Sarah and client, right? Who live this reality every day, right? So Sarah is really responsible for the front end of the process, right? Spends her time juggling high volume pre-auth requests, but she struggles to stay current on the ever-changing landscape of policies, right? While coordinating between clinical teams. Right? Client, who's a clinical reviewer, spends a lot of time going through policy databases and documentation. The very expertise that he should be using for complex cases is many a time wasted on routine tasks, right? So the common point across both of them is that they're skilled professionals who are being burnt out on administrative work, right? Instead of focusing on, driving complex decision making faster to meet the deadlines and the policy guidelines that are there. But instead wasting it on admin tasks, right? So to understand this more, let's double click on the process, right? Now, if you could go to the next slide, please. Yeah. So in this, here is what it looks like, the process, right? And why the system is fundamentally broken can be viewed through this lens, right? Now, in each of you come from a different plan payer setup, right? All these boxes, might not be manual. Some of them might be automated through a system. But what we have seen is based on the size of the plan, the variety or the type of automation varies. Some are there, some have a little bit more for like larger plans, some have much less, right? So, but when I look at holistically all the steps, right, for the front end of the process where Sarah is operating, she's getting data from multiple channels, right? Faxes, mails, some digital channels, right? EDI, right? She has to validate the completeness of the information, prioritize, determine if the pre-auth is required, right? And in cases where the information is missing, she has to reach out, she or her team has to reach out back to the providers to get back missing information, and then finally determine if clinical review is needed and route it to the right team on the ground doing clinical review, right? From client's point of view, he has to review relevant medical policy, compare it to the member medical records, make that decision of approval or denial, and then send out relevant correspondence, update source system and all those things. Again, the pain points that exist is a lot of human intervention, a lot of manual touch, quality is impacted, right? Classification doesn't happen all the time, and if you don't meet the prescribed SLA, there are fines or other kind of impact that the organization has, right? So now what we want to do is, given this state, where can we use UiPath platform to bring in how will RP help, right? That's really we're going to double click into that. Now, when we introduce robots into this process, right? Robots are deterministic by nature, right? They handle any kind of rules-based, repeatable process. They're great at automating, right? So in this scenario, from Sarah's perspective, robots will help in that routine, repeatable intake process. While Sarah can focus on that, some of the complex cases and the coordination with the clinical teams. And from client's perspective, he still has to do the review, right? Bots cannot do that decision-making process, but it can help in repeatable work like generating correspondences, updating systems when the decision has been made, right? But again, increasing the his throughput, right? He's able to process more, make more decisions now, because again, some of the manual admin work is taken off by the bot, right? So again, robots are deterministic; they act, right? So now let's double click into the actual process and how the robots come in, where the proper robots come in, we can see that. So all the orange boxes that we see is where the bot comes in, right? And as I was saying, the robot, it will take the initial steps of the intake, right? From different channels, will pull the information, some extract relevant details. If it's faxes, which are images, will extract relevant details, key it into the source system. Then Sarah can from there pick it up, categorize, prioritize, right? If there are missing information, identify the bots. Bots can help in communication with the providers as well, but she can focus more on coordination with the clinical teams, right? But from a client's perspective, the bots can help a little bit in pulling the relevant medical policy information, but post that he will make some of the decision making. He will do that manually. But beyond that, some of the admin work, which is again routing, submitting the decision, relaying the status, generating correspondence, a lot of that can be done by the bots, right? Now that's where robot was playing a role. Now, if I were to double click, right, let's look at scenarios where what happens when agent is added to the mix. Now, the key difference between a robot and agents is that robots act, agents think, but they can work in tandem, right? That's the beauty of the UiPath platform, that you're combining both, right, to work in tandem. So if you can imagine agent as a brain and the robot as hands and legs who do the job, right? Agents think, the robots act, right? Now, in this scenario, we're showing you 4 agents, right? But it's really contextual in based on what your process is, right? There could be 4 agents. Again, how we design this could be 5 agents, right? Doesn't make it. I mean, the right design is based on the context and the process you have today. But in this scenario, we have assumed 4 agents for our illustration here, right? The first agent is really the intelligent triage agent, the intake agent, right? It does the intelligent triaging. It's looking at to understand which all channels it has to go to, extract document, relevant information, update systems, and really hand over control to Sarah for any exception handling, right? Beyond that, then you have the medical necessity review agent, which is really, think of it like a research assistant, where it's looking at all the relevant policies, gathering it, right? Like, comparing it with some of the medical data submitted from the member by the provider, right? and helping in making some of the decisions. So each of these agents will help in some form of decision making. So what we saw in the previous one was RPA was automating the admin steps, but the agent is now coming and augmenting and adding it further by helping in some of the decision making, thereby freeing up time for Sarah and Klein, right? And after that, we have the clinical agent, which is we typically bring that agent for complex cases like DME, SNF, those kind of complex pre-auth requests, which requires more deeper analysis or decision making, to look at policies and other kind of documents. The clinical decision agent will go through that and help in making decision for the complex cases. And finally, the decision submitter agent is responsible for taking the decisions made and then generating correspondence, updating systems, and all that, right? Now, the same steps what I was showing is depicted as part of the diagram, right? So as I said, intake agent is responsible for taking data, from the intake request, and really Sarah does the exception handling. And from a claims perspective, he's helping make those complex decisions, right? Simpler decisions the agent can make. If there are any exceptions, he can handle, but he has now more time to focus on the really complex and urgent cases which has to move fast, and where which previously a case which would have taken half an hour, now we can act on it maybe in 5-10 minutes. It's able to move much faster. As throughput is increased, more decisions are going through, being published throughout the day, right? If for complex cases, again, that as the clinical decision agent combines and works with the medical necessity review agent to make decisions, and finally the decision submitter agent is submitting and publishing the results out, right? So given this background, right, what we are seeing here is a fundamental shift, right, in how we operate from humans doing repeatable work, which is robot-like work, to robots and agents supporting human expertise, right? So this is really about replacing clinical judgment. It's about really freeing up clinicians to apply their judgment where it matters the most, right? The result, what you see is that better patient experience, right? Reduced burnout for the employees and regulatory compliance, right? Now, to take it forward, I'm going to hand it over to Sophia to do a live demo on what is the art of possible and how we see this going live. Sophia?
So we are going to walk through an end-to-end prior auth request process and decisioning. Before we jump into that, I want to take just a second to kind of peel back, how does an agent get constructed? So an agent's going to have a few foundational elements. There's always going to be a large language model and a set of instructions. So the instructions are going to tell the agent their role and their goal in the process. In addition to that, we're going to layer on context, tools, and escalation. So context is really, really important. This is the difference between kind of a generic agentic solution and an agentic team member in your organization. They're relying on your policies, your procedures, your training documents. Tools, which can be those the robots, APIs, and then escalation, right? Always being really thoughtful about where does a human need to validate or escalate in this process. So we're also always going to have an input and an output to the agent. So if we think about our intake agent, it's going to start off with that prior auth request form. And the agent's going to look at that with their instructions and their understanding, and they're going to use that to create a plan and execute on that plan. So in this case, our plan is to, search using those contexts, validate details with a human if you need to, create the case, and then pass it off to the rest of the process. All right, so getting into our end-to-end demo flow here. This canvas is really important. I think it was alluded to earlier by both Harsh and Prashant. The transparency of seeing where all of these things are coming into play as opposed to an isolated point solution. So it's very clear for me in business process terminology here to kind of see exactly where automations are happening. So we're going to highlight agents in blue, robots in orange, and human escalation in yellow. So across my process, I can see very clearly who's taking part in which parts of the process. All right, so to kick it off, we're always going to have intake, right? And most popular would be facts. So we're going to start off with our facts intake. And we're going to use our document suite products here to do a couple of key things. Classification and extraction. So classification, I want to understand, does this document have a prior auth request form attached to it? Or perhaps it's just a set of clinical documentation and we can index this against an existing request in our system. Or maybe it's a car wash flyer and I actually don't want to bring it into the system at all. Then extract the information, right? And I'm going to be very prescriptive about the fields I'm expecting. I'm looking for CPT codes, descriptions, units, start dates, end dates, servicing providers, referring providers, stuff like that. And that's something that we can then drop out to a human for them to validate some of those details. So this would be an example of that experience. As a human, it's very easy for me to see the record on one side, and then my predicted values on this side, and I can kind of simply go through that and say, yes, this is the member ID, this is the NPI, this is the service type. And then I'm going to push that into our first agent, which is this intake agent. The goal of this agent is to build the case for downstream processing. So you can see as this agent runs, it's identified the type of request, it's identified the type of review that needs to happen, and it's identified all of those key details around the member and the provider and the diagnosis. At this point, we're going to determine the urgency, and this is a standard request, and we're going to pass that off to our next agent. So this is a different agent, and this is the medical necessity review agent. So this agent's goal is to identify across these different specific policies the criteria that needs to be met in the medical records and compare that to the medical record. The outcome of this agent is going to, again, be surfaced to a human for that level of validation. This experience I get super, super excited about because clinicians get excited about it. So this is where I'm able to see the record on one side, and then I can see what the agent has summarized as the criteria that needs to be met and where it has been met in the record. Specifically, the citation functionality is really excellent, right? So instead of scrolling through a million pages of records, it's super easy to navigate, hop through the citation, and I can say, yes, I can see very clearly where this criteria was met, jump to the next criteria. Yep, looks good. I'm going to acknowledge all of this, and I'm going to go ahead and submit my request. And it's going to kick off the rest of the process. So it will, further go down to the communication generation and send letters to provider and member.
No, Sophia, this is amazing. I think this is the power of how the platform is leveraging not just your IDP capability, but leveraging your bots, leveraging your agents. I think this is the power of all of the components of UiPath platform coming together with clinical expertise to be able to articulate and solve this problem. So one of the things we have heard sometimes customers say is, hey, this is, I think what you highlighted was a solution on UiPath Action Center. Sometimes our clients will say, hey, can I have a custom UI? Can I have a front end? And one of the solutions we built is on UiPath Apps, where we can create a custom front end, and the request is focused on, can you do all of that, reading the document, extracting the key elements. If we are comfortable and we have tested that, can you show us essentially just the decision support part of it, right? The stuff that clinicians get excited about. Here is the guideline, show me the evidence in the medical record. So I like to a little bit do a demo of a solution on UiPath apps, on how that's something that the team has developed, and hopefully you guys can see that. This is a setup where
Meet John.
we are talking about element from a record from John. He has a DME request. He has lumbar spondylosis. I'm messing the name up, my apologies, but basically a lumbar spine issue with chronic lower back pain. And this is the focus of, this is the medical record that we received, is synthetic data for PHI reasons. We have picked this record to be able to showcase, okay, if you receive this information, maybe a 20, 30 page document with face-to-face encounters, clinical notes, how would this system actually work? There is a standard written order, there is a physician order. what would happen in this case, right? And I think as Sophia outlined, if you upload the document in the background, right, there are a few things that are going on, right? Not all the things necessarily need to be visible. Sophia showed you an internal view of how essentially the process moves from step by step. You are digitizing a fax document that's been received. As you digitize those documents, you have to extract the key elements. You're reading the documents, extracting those elements, and then essentially you have to answer certain clinical questions, right? In DME, there may be 17 questions in the checklist that your team has, and the agent needs to answer those questions, extract all those elements, use the relevant prompts that are needed. In this case, when you get into high complexity scenarios, there is an agent that's specific to each and every clinical use case, right? Because you're training them on that data, right? You also have to figure out, as we were talking about the 4x2 matrix, you got to figure out whether it's an urgent request, right? So you have to go through the request itself and see if there is any reference in those 20 pages that you received over in fax where it says it's an urgent request, so that you have now a different SLA to adhere to, right? So you'll go through, in this specific case, if you go through the document, you'll find out that in the 20-page document, we have not seen any indication in any of the forms that we reviewed where it has any reference to whether it's an urgent request or not, right? So this is simply from a workflow standpoint, whether you're following a standard or an urgent workflow, right? So it's important because for our regulatory reasons, you have different SLAs that you need to adhere to. But also from a patient care standpoint, it's important as well, right? So you want to make sure that you're adhering if there's somebody's folks are going into surgery or anything, that you're answering all of these things urgently. So in terms of, then there are additional questions around any billing or claim data that may be there as the additional service has been rendered already. But specifically when it gets to guidelines, is there a written order that exists? And in this case, the system looks internally. We are showing you internally what an LLM does. It's finding that there is a standard written order. There is a question around whether there is face-to-face encounter, which is a guideline question for DME. Yes, there is a face-to-face encounter form. It's signed, is there, so these are key elements which are, is there any indication of inpatient stay? There isn't an indication of an inpatient stay. So that's there. Is there an evidence of back pain, right? I think if you think from a DME standpoint, what's most critical? Yes, there is an evidence of chronic lumbar pain. There is mechanical instability. So it's capturing that the mobility is impacted and hence, leaning towards approving the prior auth towards moving forward, right? So these are the key elements when we get into answering the key questions that are needed. And we are giving you a little bit of a view into how an LLM is responding, whether the written order exists, whether the signatures exist, whether the evidence of back pain exists. In this case, as I was mentioning earlier, we have trained about 15 or so clinical agents, whether it's for DME, whether it's SNF, IRF, that are pre-built and ready to go to, ready to have an impact on your prior auth process. And there are about 20 or so additionally in development for additional clinical use cases, right? So I think that's the power of the system. I wanted to briefly share with you, not only is this possible in UiPath Action Center, it's possible in a custom UI built on UiPath apps. It's also possible leveraging these agents in your custom workflow as well, right? So all of these are opportunities for us to be able to bring to bear the knowledge and the work we have done with our clinical teams to your benefit. Over to you, Vinit.
Yeah, I think thank you, Sophia and Harsh and Prashant. I think not only sharing and bringing the possibilities to life, but these are examples of engagements that we are actively delivering for clients. And I think our capabilities continue to keep expanding. And these are not systems in proof of concept. These are systems in productions right now, live, creating a tangible impact for clients who are utilizing them. And I think what we find exciting about this is we understand that different client set are at different phases of the journey. I think what is beautiful about this entire solution engagement approach that we have is it adapts into your existing investments, whether it is investments with related automation that you've made, investments with related to AI practices that you have made, investment with related to experiences that you have made. Our intent is to come in and anchor those investment, not replace those investments, and build on top of it. This is not a turnkey replacement solution. It is a transformation first adaptable solution that fits in your environment. And I think we have clients who are looking for outcome-based engagements in the most regulated setting there is, whether the data cannot travel outside the boundary of the premises that they are in. So we have found solutions using AI way in the same method to solve for these situations in in those settings. So I think towards that end, I think we feel extremely confident about the impact that we can make. I think what you see in summary is the impact, especially in low, medium, high use cases from a high degree of automation, which is 90% to all the way 50, 60% in high complexity use cases. Whereas in very high, I think the human intervention continues, but the power of the solution is are places where automation makes sense. I think to the checklist that Harsh spoke about for complex use cases like oncology, I think we only go half the way where it makes sense to configure such solution components. I think one other element that I wanted to throw out, I think, where do you start, right? I think considering that if you have already started, where do we pick up, right? Give us an opportunity to have a conversation with you. I think there are opportunities available for us to do a quick POC just to show the power of the solution or picking up a specific use cases or a sub-process area. I think both Sophia and Harsh highlighted that, and doing a starter kit engagement to deliver the outcome. Or I think there is end-to-end managed pack solution that can probably make the entire solution happen in a longer time frame. So I think all those options and choices are available in front of you. I think towards that end, I just wanted to also excite and encourage you to become part of the Fusion community or the prior auth community that we've built out. I think we have monthly newsletter that goes out as part of this community. I think we will be celebrating this community in addition to meeting all our healthcare customers, not only for prior auth, but for all the other problem statements that we are solving with our payer customers. Sorry, I have my productivity agent in my room trying to check whether I am performing well on this webinar or not. And I think he's trying to add his contribution or comments. I think I wish if it was more eloquent, but it is not. I think, but we'll open the floor to questions at this point in time. I think I already see some questions buzzing in the chat, and we'll probably try to order them in an order of priority. I think anybody, I think Harsh, Prashant, Sophia, if you guys would like to take a stab one by one.
I'll take the question number second and the third. I think, because it's relevant. I think in certain conversations I've recently had, I think one is a question around, yes, the current administration has signaled some more support for AI-enhanced prior auth. We are quite engaged in some of those conversations. We are engaged in some RFP, RFIs with CMS as well. And to that end, I think I would suggest that are there changes, additions expected? I would say yes, there are changes expected probably in that space. What we have seen in this, at least in the conversations we have had, CMS also is expanding their, I guess, the number of services that they are going to do prior auth for. In traditional Medicare, that expansion is going on. There is a CMS Wiser RFP that we recently responded to. So we see that expansion going on. I also do see that states' regulations are likely to go above and beyond some of the federal requests. And I think that's traditionally the case in certain states, California, New York, Massachusetts. These are the states that typically end up asking for more than what the federal ask is. So is there changes? I think we are quite plugged into those changes and happy to share that in more detail. So that's the question number two. I will take the question number three, which is around oncology. This is back to my Anthem days. When I was at Anthem, I know we tried IBM Watson to do the prior auth for oncology. And that time, I think the technology wasn't quite there yet. This is again going 10, 15 years back. I would still say for very complex use cases, the way to think about this problem statement is to automate the intake, automate the data extraction that's relevant to the nurses. So improve the productivity, but leave the, I would say, the decision-making component of it right now still very much to the clinical nurses and to the medical directors, right? It's too much at stake. The technology is evolving, and I'm sure it will at some time. I think as of today, what we have said is very high complexity use cases. You focus on the front end and the back end, and you can still improve the productivity of the nurses by 2x. And I think that's a good place to start. So those are a couple of things that I wanted to take. And I don't know if Sophia or Prashant, you guys want to
the
take
question around MCP and A2A protocol, right? So I think within UiPath, yes, you can integrate with an MCP server if you want to extend your agent in terms of the tools and the information that it has access to, you can. And as well as the A2A protocol, I know UiPath does have a strategic tie-up with Google where they are integrating the A2A protocol into the platform. So both are possible, to the question from Nikhil. And again, MCP is standard today, becoming standard in the industry, right? It's being adopted widely. To extend the agents, you have to use them anyway. And the beauty of the platform that I really like is you don't have to just build agents. You can also bring in agents from other SaaS providers and orchestrate it on the UiPath platform, right? So there is a broader orchestration play here also that you can extend you can use the UiPath platform to extend your solution further.
I think just to be fair to all the questions, right? I know you guys cherry picked the ones that you were comfortable with, but in the interest of being fair to the folks that you have asked all the questions, let me go top down, right? Okay. I think the first question that we have is outside of CMS mandate compliance, where agentic AI can really make a difference in prior auth. That this came at the very beginning of the conversation. I think we touched upon, I think, the quick wins and places where it makes sense. I think unless you guys would like to take another stab at it, I think we can probably go one by one.
Yeah, I agree with that. I think, irrespective of the compliance, it's not really a compliance-driven question. I think it's really a transformation question, Vinit. And I think to that end, there is just a significant opportunity to not only to take cost out, but have a positive impact to your member community, I think, and your provider community, right? So I think agentic prior auth automation has reasons to exist beyond compliance as well. So
I think we did.
Go ahead.
We did touch upon the administration being more friendly. I think the entire CMS Visor initiative that we have been part of, the chili kickoffs, I think CMS is coming up with a very community-based approach on how to tackle this problem. And I think we are leading along with UiPath team from a front in trying to make not only impact happen just at a payer, at an organization level, but an ecosystem level, and proud to be able to demonstrate some of those capabilities in those larger forums. I think we touched upon oncology a little bit. I think the next question is more focused on, is there a demonstrable ROI for agentic prior auth? Granted, we need to accomplish more under regulation. Is there a net positive ROI, automation paying for itself and more swapping admin manual costs or technical support costs? I think a very simple answer from me, and I'll let other panelists also add to it. Today, we are delivering engagements where we completely have a gain share or outcome-based model in engagement like this. So not only is there an ROI, there is a committed ROI, and we are ready to stand by that committed ROI and deliver to that committed ROI and take outcome for granted. I think that is our degree of confidence in solutions that we have not only created but delivered, deployed for clients. But I'll let other panelists add.
I think you hit it on the head there. I think, Vinit, I think we as an organization have committed so much time and energy last 3 years or so. I think we felt so strongly about this that our strategic efforts are extremely focused in delivering that value. And to that point, we have our asset development happened even prior to our client one, right? We went in with all guns blazing because we are quite confident in our ability to have an impact, right? So to that end, as we have gone live, we have gone live with outcome-based models. So, absolutely. The answer to that is an absolutely yes. And I think in our partnership with UiPath, we have made sure that we can show that impact to our clients as well, right? So absolutely. I know there are a couple of other questions there. If you want to go down, I think there is another question on AI units, I believe. I don't know, Sophia or Prashant, if you have insights. I think it seems to vary, I think, is sort of my understanding of it. And I don't know that it's a direct answer there. So
there's no clean answer, right? I mean, again, it depends on how you design it, right? There is the AI unit, it's the size of your prompt, right? How much context you're providing, all that. So a lot of design elements coming out in the control of the AI units too. Right. And I think that leads into the next question around the privacy, right? The PHI and all. So again, UiPath has a trust layer where you can configure some of these things, but there are a few ways to solve that. One is UiPath also allows you to bring your own models, right? One is if you're hosting your own LLMs, obviously in your tenancy, that solves the problem. That there is a concept of private GPTs where you can take a GPT like a OpenAI model and host it on Azure, which is again within your tenancy, and have it linked to UiPath setup again with, so you control the data where the data flows, right? So there are a few ways to solve this problem, but it's definitely solvable.
I would just
Yeah,
add to the
add to-
privacy, the platform is HIPAA compliant. We have all the certifications and attestations for that. In addition, we have PHI masking capabilities. So there's a ton of governance and control around this.
Yeah, to the point I think Prashant and Sophia made, this is also one of the things I think, Vinit, you were outlining. We have clients who have broadly put guidelines. These are CMS max. They have said, hey, the data never leaves, our structure. And to that end, we have implemented some of these capabilities in an SLM structure as well, where it's an on-prem structural setup, and some of those capabilities exist as well. So I think in healthcare, there couldn't be any more important question than privacy and compliance. I think we take that extremely seriously, and we have, I think, the spectrum of answers that you have heard from Prashant and Sophia and myself. I think we provide that coverage across the board.
I think one other element that I would want to add from an AI units utilization perspective, I know extraction or IDP is one element where AI units will be utilized in addition to agents. Now, the guardrails concept of governance that is inbuilt in UiPath platform, it's not only gives you an ability to control cost, it gives you an ability to control performance, quality, data access. So I think it's one of those most holistic solutions that are available out there, unlike the lessons that a lot of us learned during cloud modernization and cloud experience, where it was a death by fire. I think UiPath has some of those guardrails inbuilt by design. And I think a lot of our clients find power as these solutions get implemented to control and administer the utilization around AI units. I think there are elements of cost impact of questions versus bot versus agentic. I think, and panelists can add to it. I think my experience has been the degree of automation, as I think we were showing in our workflow slides, significantly improves as you go the agentic route. So like from a degree of 50-60% automation possible, you go to an 80-90% automation possible, and the incremental ROI that you receive on your incremental investment is a function of 3 to 4x. So it's a better ROI than what your original investment will bring. And because it is in tandem with your existing investments, there is a plus effect or a domino effect on your ROI in general. I think there is a question around reusability of process flows. Absolutely. I think we spoke about the flexibility of the solution. We will come in and look at what existing investments or process turnarounds or automations that you have done, and our solution will become complementary to what your existing investments are. I think anything around cost or usability before I go to the last question?
Yeah, I would just simply say, I think, we have developed some of those reusable assets, as we discussed about clinical agents, and Sophia also demonstrated the ability to, from a document understanding and an intake standpoint, right? So I think all these are reusable assets. They are not necessarily as custom to client. These are reusable assets that are developed and available to you to speed up delivery. I think to the point of quicker turnaround, absolutely. And that's actually what we are most excited about sharing is we have made these investments already, and we are excited about its impact to you in speeding up the time to value.
I know there is one more question. I think I want to be judicious to everybody's time. I think we are 2 minutes over the scheduled time. Considering we started 2 minutes, it does not give us a reason to stay over 2 more minutes. But I think, first of all, I want to thank everybody for taking your time, showing interest in what we feel is a huge industry problem. And I think we feel very confident about the solution that we have and the capabilities that we have built and we have deployed and demonstrated and created value for clients. Would absolutely look for an opportunity to have this conversation with you guys. We had a couple of poll questions where we would have wanted to test some of that interest, but I think we can nevertheless send this over to you offline. I think if there is a question or two that we have not answered, I think we'll compile all the questions and all their answers as a send out to this webinar. Once again, thank you from all of us here at UiPath and Genzeon team, and we look forward to working with you hand in glove and making some real impact on the ground.
Thank you. Thanks, everybody.
Have a wonderful day ahead.